All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is a discussion on cachexia in the palliative care population, and we are honored to be joined by our distinguished guest, Dr. David Bloom. He's with the Competence Center for Palliative Care from the University of Hospital Zurich in Switzerland. He's an internist by training, then worked in oncology, and now does inpatient palliative care on the wards. David recently has co-authored Top 10 Tips Palliative Care Clinicians Should Know About Cachexia in the Journal of Palliative Medicine. David, welcome, sir.
Thank you for the invitation and the nice introduction, Martin.
Absolutely.
It's nice to be with you.
Likewise. I appreciate it. Our format for today is going to be a bit of an interview. So David and I have agreed to about 5 or 6 questions, and then we hope to have a few minutes at the end for audience to ask whatever they want. So I'm just going to jump right in. So David, as clinicians, we've kind of talked about how our tendency is to always reach for medication. We want that pill. We want to fix people. And I see mirtazapine, for example, being used all the time. But cachexia, it's just not that simple. And your paper summarizes a lot of the limited evidence for medications. Despite that, are there any medications you use? Is there anything you found that's been helpful?
Yes, in a way. So, of course, we all want the magic pill to cure cachexia, but we don't have it. And it's not so easy because cachexia is not a simple syndrome, because this is multifactorial syndrome. So one way treatment is probably not enough. So it's not only medication, it's not only nutrition, it's not only anti-inflammatory treatment, it's not anti-cancer treatment. Cachexia is often in cancer, but as well in end-stage lung disease or heart disease. Let me put it that way. So there are many symptoms that prevent patients from eating. So if someone is suffering from pain, it's very good to treat the pain. If someone is suffering from stomatitis, you should treat stomatitis or constipation, etc. So proper symptom management is really important. We quite often use prokinetics. We use laxatives. So this is in order to make the gut working. But then you were hinting towards appetite regulation. And there are no really good drugs. So steroids, they have really strong anti-anorectic how to say, they act anti-anorectic, but the problem is that they as well speed up muscle depletion or muscle catabolism. And since cachexia is in a way a muscle disease, they worsen cachexia. So it's not a good treatment for cachexia. So I sometimes give mirtazapine, as you said, but there was a year ago, I think there was a randomized controlled trial.
Yes.
I think and this was negative. I think it was from Egypt.
Yeah.
But if people have maybe problems with sleeping, are a bit depressed, and have anorexia, you could give it a try. I don't know whether you saw it. I think in the beginning of the year, there was quite a big publication in the JCO about olanzapine, but that was given concurrent to chemotherapy. So olanzapine is somehow an antiemetic given in highly emetogen chemotherapy. But in this trial, they just gave it not only 3 days, but 12 weeks. And they could show that appetite and weight was improved along chemotherapy. So that's not the later palliative care population, but like if you talk about early integration of palliative care, so concurrent to anti-cancer treatment, I would say you could try or give olanzapine a try. And then I think there are a lot of studies out there with cannabinoids in different formulation. There is the problem. So like the big phase 3 studies, they were mainly negative. So I think it's not a very good medication we could propose to all the patients, but if patients require it, so for various reasons, you could give it a try. But if somebody doesn't want it, so in all the studies, cannabinoids, about a third, they quit because of side effects like dizziness, etc. And so if you are living in Japan, there is one drug, onamorerin, I never can pronounce it, synthetic ghrelin analogon, and this has been approved for cachexia treatment, but not in the US and not in the States. So the big Romala trials, they could show some improvement in appetite and some improvement in muscle mass, but not in muscle function. And therefore, the FDA and EMA said, no, we don't approve it. But maybe this will be out. So I think modern anabolics, ghrelin analogons, they will come someday in the next 5 years. But still, since it's somehow supportive medication, if they're like these novel drugs, they're quite expensive. So we will see. But I think, as I tried to say before, it's not the drugs, but the multimodal treatment, which means nutrition, exercise, symptom control, counseling, etc.
Yeah, agree. I hear a lot of skepticism for single agent drugs. I feel the same way. So I work in the inpatient consult service, and I've started now over the last few years ordering CRPs on some of my oncology patients in order to calculate the modified Glasgow prognostic scores. Yeah. But I worry about using the CRP in this acute hospital setting where there may be other confounding reasons for why people have systemic inflammation. Like maybe they're getting admitted with pneumonia and they have cancer. Are there pitfalls or wisdom you can offer us about how to use these CRPs and how to use the modified Glasgow prognostic scores?
So you're perfectly right. So in a way, in Europe, CRP is the standard measurement of inflammation. So it's common. Everyone does it, and of course it's elevated if you have a pneumonia or other infection, and a lot of our patients they have like different things together. So, but as a longitudinal outcome parameter, or to classify cachexia with high systemic inflammation or not, I think it's helpful. But as with the drugs, it's not like the one single factor that you can use. So it can maybe lead you through, but it's not like very super specific, not at all. And maybe one point to the modified Glasgow prognostic score. So I think in a way this is a twofold helpful, because albumin goes down when you are suffering from malnutrition, and goes down when there is systemic inflammation, and CRP goes up. So I think it catches the problem of cachexia very well, because in a way it's twofold unfortunate. So you don't eat enough, and you have systemic inflammation, hypermetabolism, hypercatabolism, and so it's detrimental. So I think that's why this is a really good prognostic score, because it covers different aspects from cachexia.
Mm. Yeah. David,
and maybe so, but I think so sometimes we give anti-inflammatory medication, non-steroidal anti-rheumatics, etc. And if you have a high CRP, so you rather give a try than if you have a low CRP, or when you have a low CRP. But so I have not a fixed threshold or so where I do this. And I did my PhD in Norway, and they drink a lot of fish oil, and so some people take it as a decision aid to use fish oil in anti-inflammatory intention.
Can you share with us just a little bit about the transition? It seems like a nebulous transition from cachexia to refractory cachexia. I'm sure it's black and white, right? You can obviously tell.
No.
So
that was somehow part of my PhD. So I wanted to have this single factor, or that turns people from cachectic to refractory cachectic. So in a way, you could say if you have an uncontrolled cancer disease at the end of, or in an end of life situation, anyway, cachexia is refractory. But the other factors, I think you only find out after treatment attempt. So first you try to treat the cancer, you try to do nutritional counseling, and that's really important. You try to people to move and exercise, but not all can, of course. But in my outpatient clinic, I really promote nutrition and exercise, because a lot of patients, they don't take enough energy and protein, and they don't use their muscles enough. So I push them a little, very kindly. But usually I say maybe one day we have to change the concept, and then we have to take the pressure out. So, and this is the moment when cachexia turns refractory. So in the treatment, you feel like it doesn't help anymore. The patient is not able to do it anymore. There's no simple reversible factor, and then it's important to take out, like, from the so maybe pressure is a bit too hard word, but we try to motivate them to eat and exercise. So here as well, no simple one factor answer. So
gotcha. Yeah, I like that answer. You try, but it doesn't respond. And that kind of fits with the Delphi classification system. I mean, they define refractory cachexia as any degree of cachexia in the last 3 months of life, and when the disease is no longer responsive to treatment. So I guess we could say the same thing for appetite and weight. You kind of already touched on this a little bit, but maybe I'll ask it sort of again. Looking towards the future, anything that seems particularly promising?
So in a way, I think it starts with screening. So of course, because it's not easy to treat, so it's underdiagnosed and undertreated. So it's not easy to treat. It's not so easy to detect. So because in a way it's muscle loss, and for instance, you have this sarcopene obese people, so they lose muscle, but they have they keep their weight. Maybe they have edema or ascites or so. So it's not always so obvious that there is some cachexia development going on. So I think so. Assess, stage, not only stage the tumor, but stage the host. So look how his nutrition situation, how is his muscle situation, etc. And then start a multimodal therapy, which is quite not burdensome, but it's you have to a lot of different things in a way. And there, I'm quite sure that combined with multimodal therapy, there will be drugs or soon. Yeah.
One last question before I open it up to the audience. If we palliative clinicians can really only come away from your paper and this conversation with one single most important take-home point, what would you like us to remember and implement in practice?
So, yeah, I would say acknowledge cachexia, look out for it, treat for it, and don't think cachexia is only refractory cachexia. So detect early. Go along with your patients through the whole trajectory, and do good palliative care, like end of life palliative care at the end. But for instance, there are some patients, they have really early in the trajectory, really like bad taste and smell alterations, and that like takes them the last will to live. And there it's worth like having a try with olanzapine, mirtazapine, cannabis, or whatever. So it's not also in the Corona pandemic. So we were before very interested in taste and smell alterations, but cachexia research is just a small bunch of people. But then it got wider attention, and this can be really hard if you have these symptoms.
Gotcha. Thank you. So we'll open it up for questions if there are any. And while people are thinking, I was going to comment that the two drugs you kept talking about were mirtazapine and olanzapine. I think those are the two.
That's the two I usually give for appetite stimulation at the end of life, and we give quite often steroids. So a lot of our patients have steroids on different intentions, but like if somebody, for instance, wants to go to we're in America, Thanksgiving meal and has absolutely no appetite, it's it's a real relief, but not early in the trajectory, because for the muscle it's bad.
Sure. So Richard's got a question. He's asking if you've got any advice about some of the doses for olanzapine or mirtazapine in some of these studies. And if I don't want to put you on the spot either, if you don't have them, I've got them.
Yeah, no. So I think in olanzapine is 2.5 milligram, just
that are fine.
And I'm mirtazapine. I think you start with 12. Is it? I think in Switzerland it's 12.5 or 12 or so. So yeah. And I think so. It's not if you have an effect. So of course, I assume psychotic people they take olanzapine in very high dose, but you just go low dose, and I think don't increase much higher. So maybe you can go to 5 milligram and see if it's a bit better. But the study was with 2.5 milligram.
Yeah, the more recent mirtazapine study, the double-blind placebo-controlled trial was done, I think, with 15, which is exactly what you were
15,
saying.
no, yeah, it's 15. 15, 30, 45. Yeah.
And I want to say the rationale behind that is because 15 and lower tends to have more of a histamine impact, which may or may not be part of the reason why maybe it affects some of the appetite. So,
yeah.
All right. I think that's all we've got for questions, David. We deeply appreciate your time today. We appreciate all the research that you contribute to the field. Thank you. And enjoy the birthday party.
Yeah, it was a pleasure. Have a nice working day and hope to see you sometimes. Bye. Thank you very much.
Bye.